Go ahead and get started. Just going to share my screen. Can everyone see okay?
Yeah, that's good.
Hello?
Yep, that looks good here.
Okay, awesome. So glad to have everyone here. I'm just going to be giving a quick talk about the different therapies we have for COVID-19 right now, and just kind of talking about the good, the bad, the ugly. And you'll hear a rant from me about the state of the evidence that is currently in the literature. So why don't we start off with the ugly first? So hydroxychloroquine is one of the medications that has actually gotten a lot of media hype lately. Some of it's justified, some of it is not. A lot of it actually is not. And this is something that's been championed by the media, especially Donald Trump, who's discussed about how there's a lot of purported benefits, how this is going to be a drug that's going to change the landscape and practice for caring for COVID-19 patients. So it's an interesting concept because hydroxychloroquine is traditionally used for malaria prophylaxis, and it's also used in certain autoimmune conditions like dermatomyositis, lupus, etc. And the way it works, and it's a very interesting application, is if we look at how SARS-CoV-2 actually infiltrates cells and actually propagates the infection, it starts off by binding to this receptor called ACE2 receptor. And then once it does that, the cell basically takes it into an endosome, and then it goes through a series of processes where it becomes part of the cell, takes over the cell's machinery, and actually starts to replicate the virus. And one of the things that hydroxychloroquine does is it interferes with the ability of the ACE2 receptor to bind the SARS-CoV, and therefore it can't take it in. And it also potentially has the effect of destroying the endosomes and making it a very unfavorable environment for the virus to actually flourish. And so in many ways, it actually can prevent infection in that regard. As an added bonus, it is an anti-inflammatory, so all of the downstream cytokine release and cytokine storm that you get with SARS-CoV infection may be attenuated or kind of just brought down a little bit with hydroxychloroquine. And so that is there's a fair amount of biological plausibility. And when we kind of look at whether or not this has worked before, sort of, but not really. It's been shown to be effective in vitro or in a lab setting where they've given this medication to cells on a dish, and they actually have been shown to reduce the virus replication. It actually has been tried in influenza studies before, where they've actually tried to give it as a sort of prevention, and it didn't actually work at all. And that was done in actual patients. So the hype now really is, like we said, there's a fair amount of biological plausibility. It's pretty cheap and already widely available. It's not a new drug that we have to go through the rigmarole of proving that it's safe and effective in humans. And because it's got this, established safety profile, it's ready to go right off the bat if we can show it's effective. And I say safety in quotations because it does have adverse side effects. It does have a lot of cardiotoxic effects. It prolongs your QT and causes worsening dysrhythmias. But at the same time, if we can prove that the benefits justify, it can be given to patients almost right away. And so when we look at the studies, there's kind of a lot of different themes that we take when we kind of appraise studies in the literature. But I mean, the two broad considerations that I'm going to put forward are, the first question is we're going to ask ourselves is, do we believe the results? And this is essentially a way of saying, are there systematic errors that can actually distort the truth in the studies that we're going to be looking at? And that's called the risk of bias. And then the other component is, okay, so provided that the bias is low, can I actually use the results in a very clinically meaningful way? And then if a patient with COVID-19 is going to read this manuscript or this publication, will they actually care about the outcome that the author studied? And if you look at the evidence to date, there's about 6 clinical trials that have been published evaluating hydroxychloroquine in COVID-19 patients with a total pooled number of 406 patients. But the problem is, like we talked about, that a lot of these studies have methodological design choices that make it very hard for us to believe the results. So for example, researchers often decided who they wanted to enroll and who they didn't want to enroll. They ultimately not every study was randomized. Not every study had allocation of concealment, which is the order in which someone's going to get the intervention and who's going to get the control. And many were actually unblinded. Some studies went as far as excluding patients but didn't have any outcomes, and therefore that leads to incomplete outcome data as well. Of those studies, there were really two that were positive. And there was one study by Chen and others that showed that there was an improved time to clinical recovery with hydroxychloroquine. But when we look at what they meant by clinical recovery, they just said that cough and fever symptoms were reduced by a day. They also said that the chest CT looked better with hydroxychloroquine therapy. So not all that convincing. The other study that is worthwhile mentioning perhaps is a study by Tang and others, which showed they couldn't show any meaningful clinical benefits on a patient level, but they found that CRP was improved with hydroxychloroquine. And we look at this and we wonder what's the significance of reducing the CRP by 6.99 versus 2.3 in the hydroxychloroquine and the control arm. They also found that hydroxychloroquine had a lot more adverse effects as well. So just based on the literature we have right now, the most recent one, a lot of these positive results are really not clinically meaningful or important to patients. They're hypothesis generating at best. And while the big catchphrase for a lot of research studies is that you always need more research, in this case, we really, really need a lot more research to actually really convince ourselves this is worth taking the risk for. There's a high risk of bias with current studies, and if we were to actually evaluate the certainty in the evidence, it would be very low for both benefit and harm. There's actually a lot of studies that are ongoing to address this. Just doing a quick search on clinicaltrials.gov, there's actually about 29 registered clinical trials that's going to answer this question. And there's actually one by the World Health Organization that we might be participating in that can help answer this question. I mentioned this and I say this because the FDA has given emergency approval for hydroxychloroquine, but it's really hard to justify based on the data that's out there. The other the drug that's actually gotten attention, and there's probably a bit more credibility here, is Remdesivir. And actually, it was Dr. Fosi who recently said this line that this is not necessarily a total answer by any means, but it's an important first step. And while the initial results may suggest some promise, it still requires us to proceed with caution. So how does it work? Going back to our picture with the SARS-CoV-2 virus and the cell and the receptor, essentially what happens is as SARS-CoV is taken in, it ends up producing viral RNA that gets released into the cell. And then eventually it actually takes over the cellular machinery and it starts to replicate all the RNA particles. Then that essentially produces more virus, which just spreads and it propagates the infection. What Remdesivir does is that it actually emulates a building block of the viral RNA. And so it kind of stealthily gets into the cell, it tricks the virus RNA that recruits the cellular machinery to incorporate it, and then it produces this RNA that's actually ineffective, and again, it ends up getting broken down. So it basically inhibits RNA virus replication in that aspect. And then when you kind of look at, what is the background literature on this, and what is the likelihood that this may actually work? We find that it actually is effective in vitro, so in a lab setting against all coronaviruses. And the ones they looked at were, I believe, SARS, MERS, specifically. They did actually look at it in Ebola, and it was proven to be effective in a lab, and they actually started to trial it on humans, but it didn't show any benefit in Ebola patients. So people thought, well, we already established a safety profile for it from these Ebola trials. Why not just try and see what we can get in the setting of COVID-19? There's actually just one double-blind placebo-controlled trial that was published about a week ago in the Lancet. And as far as studies go in terms of what's coming out there for COVID-19, it's actually one of the better ones. Its overall risk of bias is low. It was a blinded study, allocation was concealed, the randomization was actually done quite well. So I actually had no issues at all with that. They did happen to find there's no benefit with Remdesivir to improvement in clinical outcomes. The problem with this study, though, is that it actually was stopped early. They meant to take it to around 450 to 500 patients or so, but they had to stop around 237. And the reason for that is because they just ran out of patients in China, just because the COVID-19 was under control at that point. If you look at the original study, and I'm happy to provide the reference if you guys want it, they actually use an interesting outcome scale. And so what they did was they used a ranking system on a scale from 1 to 6, where on the one end it's death, and then the other end is hospital discharge. And then 5 was, I think, on ECMO or requiring mechanical ventilation. 4 was you require like NIV or high flow. 3 was you're in hospital on oxygen, but like not as bad as high flow. And then 2 is you're just in hospital, not requiring oxygen. And what they wanted to show is whether or not you can improve yourself, like patients are improved on that scale when they take remdesivir. And I do have an issue with the ordinal outcome scale. It has been used before for flu trials, I think maybe about 10 years ago or so. But the issue with that is that it's hard to know the meaningful difference between one point to another. So, being on ECMO and then getting off ECMO, but still being mechanical ventilated may not necessarily be as important as someone who actually gets to go home. And so that the difference between each point on the scale is not necessarily equal from a patient point of view. The other thing is that when you look at those scales, and this is not to get into too much statistics, but you kind of need to have a balanced distribution amongst all of them to actually know what your true sample size is. So all that comes down to the fact that there's a lot of factors about the study that make it hard to really know if the results they showed are actually to be trusted, and whether or not there's still maybe a benefit with remdesivir, but we haven't actually found it yet. What is interesting to note, though, is that there actually was no impact on viral load, which is a bit odd because you would expect that you would find, if you can't find a clinical difference, you might actually find some sort of reduction in viral load. And that's, after all, the entire basis for why remdesivir is supposed to work. And we wonder if because therapy actually started late. For the majority of patients, the average time or so to when they had symptoms start to when they actually got the drug was about 10 days. And so there is potentially an issue with that fact that the drug was given a bit too late. Recently, however, Dr. Fosi has mentioned that there was another trial that was done that actually showed benefit with remdesivir. And this was also a double-blind placebo-controlled trial of about 1,063 patients, and they got treated with remdesivir, which apparently has reduced time to recovery. The issue with this is that it's only in the news. I've only seen discussions of this in the New York Times and Forbes, and it was mentioned on TV as well. We actually haven't seen the original manuscript, so it'll be very interesting to look at this. But what we don't know is how they define recovery. Is recovery just staying in hospital but still having disability? Did patients actually end up going home? They reported an absolute risk reduction about 3.6% in mortality, which means that mortality went from 11% to about like 8.6%. 11.6 to 8%. So that means that you'd have to treat 28 patients to save one life, and we don't really know if this is statistically significant. So there are still a lot of questions that aren't answered here. Just a few honorable mentions that you guys might have heard of. Favipiravir is another antiviral therapy. There were 2 studies there, no evidence to support it. Ritonavir, lopinavir, actually also 2 trials, again, no evidence to support it. And convalescent plasma, we have a case series only of 5 patients that were reported on that ended up actually getting discharged from hospital, and they were quite sick. But again, there's no control group there. We still need a lot of studies here. And studies are coming. More trials are coming. There's the Concord trial that actually Western is participating in, and it's looking at convalescent plasma. Then there's a solidarity trial that actually looks at a lot of the drugs of interest, and also LHSC will be participating in that as well. So a few closing remarks. We do need a sober second thought about the therapies that we use. And we kind of also, from a healthcare provider point of view, have to check our emotions and anxiety. We all want to believe that studies are positive when they try to convince us that they're positive. And we all want to find a therapy or drug that actually works for COVID. But it's also important to balance that with the fact that we may feel better in administering these therapies, but we should hold off if there's really no strong benefit. We should also just check our personal biases and be weary of political and academic agendas. At least from my point of view, as an aspiring scientist, it's very easy. It's easier to publish studies on COVID-19 these days without having the stringent academic rigor that you would have had to require before COVID-19. And maybe that's motivated by the fact that people want to push out a lot of the data out there quickly and in an expedient fashion. But you have to be very careful with what's out there and just be very mindful of literature and the biases. A lot of the studies actually were mislabeled. Some of them were called randomized trials when they were not. They used heavily biased methodology, and we're seeing a lot more of a lack of peer review. So I just urge caution for people who are going to review the literature, just to kind of take every result with a grain of salt, and just kind of make sure that you bring it to a forum where we can discuss it all. And thank you. Happy to take any questions.
So thanks, John. That was perfect. Does anybody have any questions? There are only 11 people, so I think people can just unmute their microphones and don't need to type it in. Any questions for John in terms of the data he presented or the research? I guess from my point of view, John, it seems like a lot of the stuff is similar to other realms we've talked about. So the CRT and the coagulation concepts. Is there anything that so I think at this point, if we could summarize all of the therapeutics in COVID, it would be that there are possible pathophysiologic and biologic plausibility for some things, but that in general, there really aren't robust data to defend any particular thing outside of a clinical trial. Would you say that's true? Or would you say
I would totally agree with that. And in my personal opinion, I think that there isn't really a therapy out there that would make me want to jump to it and use it right now. Just because I want to feel the need to do something or to give a therapy for a COVID patient. I think a lot of it just comes down to just accepting that there's no good data. There's potential harm in giving medications that we don't know the safety profile for really well in this population. And so I would kind of be very cautious about using any of these therapies. And in fact, I wouldn't use them at all. And it's hard to do, especially because these patients sometimes just linger on the vent for, days and weeks without much improvement. And it's kind of hard to hold ourselves back, but yeah, I would support that.
Yeah, I think that sort of seems reasonable, that we're sort of left with not a lot of options. We feel kind of desperate when patients are really sick, but that there's nothing that we can say definitively it's going to help, and it's really just experimental. So it's best done inside a trial. Is there anything that you find particularly promising in terms of what you've reviewed?
I mean, I think Remdesivir, if anything, may have the best hope of showing something. I think that the effect, if it does show anything, would be modest. I'm curious to know what I'm waiting for that trial to come up that Dr. Fosi talked about. Apparently, they were analyzing the data. So it'll be interesting to review that one once it comes out. But I would say that's probably the most promising. Convalescent plasma sounds good, but again, there's really not much data out there. And a lot of things that sound good biologically and physiologically don't always pan out. So,
right. Great. Any other questions from the gallery? Okay, and if not, then thanks very much, John, for participating. And again, we'll post this on YouTube. And yeah, everybody have a great day.
Awesome.